Hi, my name is Dr. Carlos Wesley. I'm just going to give you highlights from a presentation that I gave at the American Academy of Cosmetic Surgery earlier this year. Now, there are two purposes to this redelivery of the lecture. The first is to provide an update to all the people who have been inquiring about Piloscopy and where it stands at this stage. And secondly, to give some background to the people that may not have heard of Piloscopy. It's a different approach to harvesting hair follicles. So, as a little bit of background, there's two basic objectives in hair restoration surgery. It's basically to transplant as much hair as possible into the recipient area with as little surgical evidence as possible in doing so. Now, this was a patient who was failed on both fronts by another doctor. He came to me after having had this surgery performed elsewhere for a repair. Now, this is a very rare occurrence. But the fact of the matter is, it is something that happens, and so for that reason, follicular unit extraction, or FUE, has become more and more commonplace. This is an example of the ARTAS robotic system that's used by a number of doctors that uses stereotactic imaging to punch out individual hair follicles one by one, and then the operator comes by and takes them out individually. Now, I don't use the ARTAS robot. I use a small handheld motorized punch because it's a smaller punch and has a little bit less trauma to the donor. This is a patient of mine 1 week after having had a large FUE session with me using a 0.75 millimeter punch. And you can see even a week afterwards, the donor hair looks quite good, even with a short hairstyle. So despite the increased use or the increased popularity of FUE, still about 2/3 of hair restoration surgeries performed are done with a strip harvest or follicular unit transplantation. Of the FUE cases, the vast majority of physicians still use a handheld motorized punch, potentially because of the smaller caliber size of the punch that's required. Now, to remind you, there's three fundamental shortcomings of FUE. The first is called a transection rate. And what that means is when you're punching from above, the stem cell containing portion of the follicle lies beneath the skin surface. And if you go at the wrong angle, you may cut into that stem cell containing portion of the follicle or transect it, which would mean that the graft that you're then moving may not survive. There were two very well done studies using the ARTAS robotic system, and they looked specifically at hair follicle transection rates. The first involved just Korean patients, and what they found was about 5% of the hair follicles taken with this robotic approach were transected. That transection rate jumped up to about 30% when they were looking at 5-haired grafts, when they were targeting those. This is something that isn't seen with strip harvest, meaning that when you're doing larger grafts with a strip harvest, the transection rate really doesn't go up much at all. A more ethnically diverse group of patients that was seen in New York City also comprised the next study demographic, and they found that the average transection rate in this population was about 6.5%. And those transection rates varied dramatically from about 0.5% to almost 1/3 of the grafts that were harvested were transected, depending on the hair characteristics of these different types of patients. Now, to put things in perspective, published reports from strip harvest reveal about a 1% to 2% transection rate. And again, it has everything to do with the challenging, unpredictable curl of the hair follicles beneath the skin surface. The second shortcoming is the shape of the grafts. These are images taken by one of my colleagues, Dr. Rassman, in Los Angeles, and he did a very good job of just capturing the different shape of the hair follicles based on how they are harvested. On the right-hand side are strip harvest grafts, on the left-hand side are FUE grafts. And you can see in these images, strip harvest grafts generally include more protective tissue around the base of the follicle, the stem cell containing bulb. FUE grafts on the left-hand side, when they're punched and then pulled out, they're oftentimes stripped of that protective tissue, and so the stem cell containing bulb with FUE is oftentimes more vulnerable. It's more susceptible to dehydration, the trauma being handled when it's moved from one area to another, temperature changes, so on and so forth. The value of that protective tissue was illustrated by Dr. Biener in New York, where he looked at first 2-haired follicles. The only difference was the amount of protective tissue around them. Skeletonized grafts, medium amount of protective tissue, and then chubby grafts had different survival rates that increased according to the amount of protective tissue at the 19-month survival rate from 68% to 88%. That difference was even more pronounced using 1-haired grafts, where skeletonized versus those possessing about a medium amount of protective tissue had survival rates that increased about 200%. And FUE is not a scarless procedure. Depending on the size caliber of punch that's used, the density at which the hair is harvested, punctate scars, these little white dots, will still be present. And also depending on how short a patient wears his or her hair after the procedure, you'd still be able to notice a bit of that punctate scarring. So there was a really dedicated group of dermatologists and pathologists in Spain who were performing a study on the anatomy of hair follicles. They were looking specifically at where stem cells are present in the follicles. Using a cytokeratin 15 stem cell marker, they found that these stem cells are present all along this portion of the hair follicle. This is the brown streak where CK15 lights up that shows where stem cells are. They're present all along the follicle except for this 1 millimeter stretch right before the hair exits the skin surface. Now, meanwhile, I was on the other side of the world in a train in New Haven, Connecticut, and I saw this ad, and I was thinking to myself, well, why, if everything that we're trying to harvest lies beneath the skin surface, why do we need to go cutting the skin surface in order to access it? And why can't we come from a beneath the surface approach to just take what we need? And so the first thing I did was go to the produce section of the local market and using a very basic punch, I tried to consistently punch out tissue and clip it within a millimeter of the skin surface. Once I was able to do this consistently on different types of fruits and vegetables, that's when the idea of piloscopy was born. Now, what is piloscopy? Basically, what the idea is, if you can come from beneath the skin surface and capture the stem cell containing portion of the follicle and that protective tissue around it without traumatizing the overlying skin surface, you can have the advantage of maximizing the survival of those grafts because of that valuable protective tissue, and eliminate scarring because you're maintaining the integrity of the overlying skin surface. Now, these are more recent iterations of the instrument. These were taken in the summer of 2014. It looks very busy, sort of like a Star Wars spaceship, but basically the idea, this is the subdermal arm right here. This is the only portion that lies beneath the skin surface. Everything else is on the outside. This is the instrument as seen on a cadaveric scalp. Through this tiny 1.4 centimeter incision, everything can be introduced beneath the skin surface. Now, this is the piloscopic protocol. This is how it works. First, you make a 1.4 centimeter incision anywhere within the safe donor area of the scalp, which is the area in which the hair is most likely to remain permanent. Through that little incision, you introduce the dissection tool, which uses a combination of sharp and dull dissections to go through that dense connective tissue beneath the hair follicle bulbs. Once you've established that working cavity, then you introduce the piloscope, just that subdermal arm, through that 1.4 centimeter incision, and then the instrument rests on top of the scalp. There are no cameras beneath the surface. There's nothing beneath the surface except for that tiny subdermal arm and the punch within it. The operator sits and the instrument sits on top of the skin surface. The operator sees the external portion of the hair follicle, adjusts the instrument to be in alignment with it, and then punches them out. Once the hair, and it's the portion beneath the skin surface that's actually punched out, but you're seeing only what lies above the skin surface. Once it's punched out, it's passed through a saline flush into a storage vial. And then after you've completed the harvest, you take the instrument out, throw in a couple stitches, and the only evidence you have is the little tiny slit that's just over a centimeter. These are images of the instrument as seen in July of 2014. This is what the operator sees. They see through the monitor, they see this, the external portion of the hair follicle. You're not seeing anything beneath the skin surface anymore. It's much, much simpler. It's just a tiny, tiny external portion of the hair follicle, exactly how the hair exits the skin surface. You adjust the instrument based on how it exits, and that's how you make your determination and targeting of the hair follicles. Now, in order to create this instrument, in order to realize it costs over $2 million in funding in order to create it. And so in order to prove the principle, I obviously needed to think a little bit differently and use a very basic model of a similar instrument in order to do that. So what I did in order to have this proof of principle study was take an ellipse, a tiny ellipse of scalp, flip it upside down, invert it, and then take a very rudimentary punch and punch to simulate this beneath the skin surface approach. Punching and then maintaining the overlying skin surface by not punching through it. Then taking those grafts that were harvested in this method and transplanting them in a way that we're familiar with, placing them into tiny sites. This is a video of a really basic punch that we were using early on in 2009 that would just basically prove that this has potential. This is a strip of cadaver scalp, and you can see that even the suction within this instrument takes a follicle and brings it within the cannula. And so it takes a hair that may be curly and makes it straight. Now this is sort of a bull in a china shop analogy. Back in 2009 when we were doing this, it's nothing like this anymore. I'm sure people in the chat rooms will comment on how traumatic this was, and that's one of the things that we've been refining over the years. Right now there's not nearly the trauma that you see with these nitinol handles, but this was really back in the time just to isolate the grafts, and we were able to do so. You see they have that protective tissue on them, but I want to emphasize again that now the way the instrument works, we don't have those external clipping fingers. It's something that's much more precise and just causes a tiny amount of excision, just like FUE. These were the grafts seen during the 2010 clinical trial. Typical FUE grafts have that denuded shape, and the grafts that were taken with the simulated piloscopic approach, flipping the tissue and taking it from a below the skin surface approach, were seen with that good amount of protective tissue. Now, this is a very busy slide. Some of you may have seen this, but the results from that trial are as follows. The y-axis is the months after the procedure, and the x-axis is the patients. Now, what I'm doing is I'm comparing the growth of traditional FUE grafts with the piloscopic grafts, or the grafts taken with that simulated piloscopic approach that I just described. 100% means that the rate of growth was the same between FUE and piloscopic grafts. Less than 100% means that the piloscopic grafts didn't grow as well as the FUE. Any number more than 100% means that the piloscopic grafts grew better than the FUE grafts. So patient number 1, for example, 3 months out, had the same rate of growth. 5 months out, the piloscopic grafts were growing a bit better than their FUE counterparts, and that difference was even more pronounced at the 13-month mark post-transplantation. Patient number 3 at 4 months had better growth of the piloscopic grafts, and again, that difference was even more pronounced at 16 months out. Patient number 4 initially had better growth of the FUE grafts 2 months out, but then 11 months post-transplantation, the piloscopic grafts were growing considerably better again than the FUE grafts, and patient 5 only had one data point, and at that point, 5 months out, the FUE grafts were actually growing better than the piloscopic grafts. It would have been nice to get another data point on him, but he lived quite a distance away. The results from this study showed a statistical significance. The piloscopic grafts did have about a 45% greater survival rate than the grafts taken with the traditional FUE approach. Now, those were the grafts that were taken with that simulated piloscopic approach. Now, how do the grafts look nowadays with this newer iteration, this device that only goes through that 1.4 centimeter incision? Well, first I should qualify this by saying these are cadaver grafts, which don't have as much sort of health as live tissue. But even despite that, you can see that the piloscopic grafts taken in cadaveric scalp do have a good amount of protective tissue. Now, one of the things we've been refining is the angulation of the piloscopic punch, and that's been one of the main challenges over the past summer. But you can see on this surgical glove, we did a series of about 20 grafts in rapid succession, and initially we have good alignment of the grafts, and then once that alignment is a little bit off, the grafts aren't quite as good, and it takes an adjustment, and once that adjustment is made, we start getting good grafts again. So that's just like FUE, where you have to make a series of adjustments to account for the subtle changes in angulation. Now, donor appearance. I think you'll find these interesting. First, and you've seen these in 2010, these are the 1.0 millimeter FUE punches, and then the yellow arrows correspond to where the piloscopic grafts were taken, and you can see It's just an absence of hair. There's no evidence on the overlying skin surface, just an absence of hair. Now, fast forward to the summer of 2014. This is cadaveric scalp, where 98 grafts were harvested with a 1.0 millimeter FUE punch. It's the same that's used with the RTOS robot. And then the same number of grafts, 98 grafts were taken with the piloscopic approach in that same concentration. And you can see, obviously, the difference. I want to also emphasize, through this 1.4 centimeter incision, we can harvest all throughout this parietal area, and the occipital region through this single 1.4 centimeter incision. Now, how does it actually work? Because for something to be adopted into clinical practice, it has to be as efficient as the current method. And so what I'm doing here is I'm communicating with my lead engineer in Utah using a Skype consultation. We're seeing how many grafts he can harvest, how long it takes him to harvest 10 grafts. Now, because the Skype connection was slow, we just shed the monitor, and he's just looking directly through his visor. Every time he says there's one, there's two, that means that he's targeted a graft, punched it out, it's going through the saline flush. This is what the grafts look like during the same harvest that you're witnessing right now. So Trevor was able to harvest 10 grafts in 30 seconds, which is the equivalent of 1,200 an hour. To put things in perspective, a fairly good standard for FUE is about 300 to 400 an hour. So that means that this could potentially be 3-4 times as fast as FUE, and also the grafts can immediately be implanted because they don't have that overlying epidermis, so they don't need to be trimmed in order to be transplanted again. Now, during our clinical trial last July, we had a couple patients enrolled. We took the grafts that were harvested via FUE and from the piloscopic approach and sent them off to that same group in Spain of dermatologists and pathologists for cytokeratin 15 staining. Sure enough, with FUE, we found the CK15 light up in the bulge. And also, excitingly, with this piloscopic grafts, we also found CK15 light up in the stem cell containing bulge. So this tells us that when we're coming from below, we're capturing the bottom, the bulb of the follicle and the dermal papilla and the stem cells within that. But as it continues upward, we're also capturing the entire bulge region, the CK15 positive bulge region. So that's wonderful news that we're capturing both of those stem cell colonies, which are essential for the survival of transplanted follicles. So this is just a basic summary of the theoretical advantages of piloscopy. Basically, patients may not need to shave their head anymore for the piloscopic approach. There's less out-of-body time for grafts, and potentially we can harvest more than one at a time since we're approaching from below, and we don't need to, and we can sort of shift all the hairs into alignment. So, in conclusion, this is exciting, but it's still something that takes a lot of time. I know a lot of you have been frustrated by the amount of time that it's taken, and I can tell you, it's something that takes an inordinate amount of time in order to make any minor adjustments. Last July, which was about 8 months ago now, we did a small clinical trial. The patients were comfortable and the donor areas looked great, but we wanted to perfect the alignment of the instrumentation beneath the skin surface. That iteration, that subtle change, has taken many, many months, and that is just how things work in instrumentation. We have a really talented team of engineers who's working very hard at doing this, but things take time. And so what I can tell you is that in April this year, our plan is April 2015, we're going to do another small clinical trial. And when I say small, I mean 15, 20 grafts. Just making sure that it works perfectly, then ramping up to 50 grafts, 100 grafts, and so on and so forth. We don't want to rush into 1,000, 2,000 graft sessions because we want to make sure that it works perfectly before we start doing that. So I understand some of the frustrations of people online that it's not ready immediately, but it is something that there's been a lot of progress, and I'm really happy with how it's going. And good things do take time. So I very much appreciate your patience and your attention and your interest in this. It's something I'm very excited about as well. And progress is coming. I look forward to giving you guys more updates. Take care.